start. Yes, great. So once again, thank you very much. Welcome on the MCQ for all. As you know, I'm Dr. Munjal Pandya, hemat-oncologist and bone marrow transplant fellow, and having a quite experience in hematology for more than 2 decades and wonderful coaching experience too. We have a nice team which includes Dr. Aarti, Dr. Madi, Dr. Ankit, Shikha, and its team is expanding like anything. So a lot more things we are coming up with the dental course recently and in future very shortly with homeopathic course as well. So we are preparing all the things and MCQ database and all. We are doing data flows as well. We have a lot of discounted packages. So those who are interested, inquire later on. The beauty of this whole platform is our YouTube channel, where hundreds of videos are uploaded. As of now, it is free access. Probably it would be paid in future, but get the maximum advantage as far as it's a free access. You can see one video a day will completely change your mind 360-degree for your preparation. And let's start with the our main stem. So think of each and every MCQ important recently asked questions in exam. So first question in front of your screen. An otherwise healthy 28 years old man comes to his physician because of painless enlargement of right testis. He began to feel a sensation of heaviness in right hemiscrotum. Approximately 6 months ago, physical examination reveals diffuse enlargement of right testis, but it is difficult to determine whether it is due to intratesticular or extratesticular lesion. Which of the following is the most appropriate next step in the diagnosis? CT scan of the abdomen and pelvis, serum level of beta HCG, alpha fetoprotein, LDH, lactodehydrogenase. They are the tumor markers for testicular tumors. Scrotal ultrasonography, needle biopsy, suspected malignancy, inguinal orchiectomy. So, what is the diagnosis, investigation, and treatment? As you know rightly, I mean, those who are joining first time probably they don't know, but otherwise, this is a beautiful triad. So, you need to know the three things for each MCQ. So, what's the diagnosis, what's the investigation, and what's the treatment? So, think over it. What could be the diagnosis? Then we'll discuss. Yes, anyone? If you shy to interact with me, you can post your answer in the chat box. We have a nice chat box. You can answer A, B, C, D in your chat box as well.
Yes, sir. Last one. The testicle testicular digital. To intratesticular director, what feature is the most appropriate next step in the diagnosis?
This all questions are absolutely high yield for the exams. This is recently asked. We are compiling nice database day by day upgrading as well on the website. So that will help you to crack the exam. Yes, anyone? Yes, Dr. Saniba, what's your comment? What do you think? What could be the answer?
Sir, total ultrasonography.
Okay, fine. Scrotal ultrasonography. So I'll keep your answer as a scrotal ultrasound. C. Okay, fine. Yes, Dr. Anisha, do you have any comment? Do you have any comment, Dr. Anisha?
Yeah, I think it looks like testicular tumors, so maybe a needle biopsy will help to
Okay,
diagnose.
testicular tumors. Okay, so what is the question? Did you understood the question well? Right, this is some kind of testicular tumor. Yes, that's fine, right? So what they are asking, the question is, all right, physical examination reveals diffuse enlargement of right testis. Diffuse enlargement. It's not one side. It's a diffuse, means totally diffuse enlargement of right testis. But it is difficult to determine whether it is intravesicular or testicular or extratesticular lesion. So what will you do the most appropriate next step in the diagnosis to know the intratesticular or extratesticular? Does it help? The needle biopsy will help to know whether it is intratesticular or extratesticular.
No, I
Dr.
think
Anisha.
scrotal ultrasonography maybe. Yes.
Yes, so you change your answer from needle biopsy to scrotal ultrasonography. So this is learning
Yes.
point here. Whenever you read the questions, you read it well. The beauty, right? This is even small scenario. If you see that there's a huge scenario, very long scenario, 15 lines of scenario, then probably when you are coming to 13, 14, 15 line, you forget earlier 12 lines. By my experience, the beauty is that whenever you don't understand, try to see last two lines, what they wants to explain. Try to look at the last two lines, right? Where
Mm.
you this is a game changer or this is the decision making. So probably you missed Dr. Nisha this part intratesticular versus extratesticular.
Fan
Though you
Sakamailia.
know the yeah, so though you know the answer, you probably take the wrong answer, and
Mm.
that will degrade our markings, right? So we don't want to lose any marks in the exam, right? So each and everything we should do it properly, right? So why you want to do doctor scrotal ultrasounds or why scrotal ultrasound? Why not CT scan? It is more sensitive and specific. Why not CT scan? Abdomen and
Sir, it's
pelvis. Why you don't
fluid.
want to do?
Sir, it's fluid. So, uh,
Where it is showing it is
sorry,
fluid.
sorry, it's not fluid. It's soft tissue.
Where is it is
So
written
whether
it is soft tissue? Where it is written
no,
soft tissue?
no, like it's testis, right? So we need to. Uh, I forgot the name.
You can restart your answer. I still did not understand. Here we are gathering today, right? Not just the pastime. This is in general. I am dedicatedly taking for many years, right? Just to guide you people well. We are not charging anything, right? And we don't want to. It's an educational platform. I want to know the concept on each and everybody. That's it. We don't need to mug up. Though I solved today, say for example, 10 MCQ, but it is equivalent to 100 MCQ because in one questions I will solve at least 5 to 10 questions minimum. Yes, tell me, Saniba. Why you want to
So
do the ultrasound and why not the
uh,
CT scan? This is my question.
um, hydrocele is one of the uh, cause
Sorry,
of
I'm not still getting you.
hydrocele is one of the cause of scrotal
Okay,
swelling. So
okay. So hydrocele. So
it
do
will
you
be
see? Fine, fair enough. So hydrocele by you. So is there any finding in the scenario that there is a trans
no,
illumination
no,
test is
nothing is there,
positive
but
or something? Hmm.
it's not there.
Fine.
Actually.
So let me answer you well, right? So now their question is first intratesticular versus extratesticular. There is some mass, but they don't know. It's difficult to determine. It's difficult to determine probably on the examination whether it is intratesticular or extratesticular, right? So first of all, intratesticular versus extratesticular, the ultrasonography is the best. It's a best. It's an initial investigation. You cannot bypass. It is cheap, easily accessible every part of the world, ultrasound, right? So these are the all advantage. The major two advantage of ultrasound is first is solid versus cystic. Solid versus, if it is solid, it can identify by the echogenicity. So solid versus cystic, and another thing, it can identify intratesticular versus extratesticular as well. So both things can be identified by ultrasonography. When you supposed to switch to the CT scan abdomen pelvis is when the ultrasonography is equivocal. Have you word listen the word equivocal? Equivocal, the another simple word is a inconclusive. Equivocal means inconclusive. You are not sure by doing the ultrasound that okay fine, still I am confused, it is solid or cystic. I am confused whether it is intra or extra testicular. In that case you can go for the scanning because this is more sensitive and specific, but not the initial or base test. This is the best in terms of availability and cost effective as well, right? So when it is inconclusive, you can go for this. Is that clear? Yes or no?
Yes, sir.
Wonderful. Dr. Anisha, just for your kind knowledge, needle biopsy is absolutely never ever done in any testicular tumor. Never ever done, especially when you are suspecting any patients as a testicular tumor or cancer, right? So this is a scrotal sac. Say for example, this is testis, right? And this is all epididymis and this blah blah, right? So
There is
here
a chance of spread.
excellent, excellent. So you never ever enter your needle from scrotal sac to the testis. There is absolutely high risk of shedding of cancer cells, right? So never ever do transscrotal biopsy. Never ever do. Absolutely wrong answer. So never ever do needle biopsy. What you can do is a inguinal orchiectomy. Inguinal orchiectomy. So through inguinal canal, right? You do complete orchiectomy. Inguinal orchiectomy is the correct answer, but it is not the concern at this point of time. So what is the concern here? First, you do the sonography and you try to find out whether it is intra or extra testicular. Okay, you find a solid tumor, it's likely malignancy, then go inguinal, high inguinal orchiectomy, right? Along with the tumor markers. Tumor markers helps for the staging, right? Right. So you do the solid this confirmation, solid tumor, likely malignancy, right? Once you confirm it is likely malignancy, you do CT scan as well as tumor marker, AFP, LDH, beta HCG, right? And then you go for the inguinal orchiectomy, right? So needle biopsy never ever comes in any testicular tumor, especially the malignant one. High risk of shedding of the cancerous tumor cells to the nearby tissue and spread nearby lymphatic or hematogenous, right? So this is how we have to answer, right? Our job is not just to get the answer, correct answer. Okay, fine. I'm happy if you know the correct answer, but you need to know as well why not A, why not B, why not D, and why not D. And that is the real learning point for each and every MCQ. So you have to make a practice of doing such MCQ every day, not just to get the answer, but you need to know why this, not this, that, right? So once we decided that, okay, this is tumor, it's a malignant tumor. So can anyone tell me in the house, right, this testicular tumor or malignant testicular tumor, how you classify malignant testicular tumor? How you classify it? Is there any classification? Is there any classification? Do you know or anyone know?
Seminoma, non-seminoma.
Yes. So major classification is what? Right? So major classification is like this: germ cell tumor, non-germ cell tumor. So GCT, germ cell and non-germ cell, like Hodgkin's and non-Hodgkin's, right? So germ cell and non-germ cell, right? Germ cell tumor has two entity. One is a seminoma, another is a non-seminoma. This seminoma carries 40 to 45% and this contains 60%. Seminoma is a good in terms of prognosis. Early disease you can detect. This is in general it is bad prognosis, right? So we will see bit in quickly, right? So that will clarify your thought process. So this is a seminoma versus seminoma. Before that, I would like to give you the idea what is a classification quickly, right? So this is a quick classification overview of the testicular tumors. In testicular tumors, right, germ cell tumor carries 95% is germ cell tumor, means 5% only is a non-germ cell tumor, only very less. Within germ cell tumor there are two entities, one is seminoma and another is non-seminoma, right? So this is seminoma and this is non-seminoma, right? And this non-seminoma contains embryonal carcinoma, teratoma, testicular choriocarcinoma, right? These are the 40, 50, 60% in general for your knowledge, right? And last but not the least, right, in non-seminoma, right, yolk sac and mixed germ cell tumor. So there are five, six category non-germ cell: embryonal carcinoma, teratoma, testicular choriocarcinoma, right, yolk sac tumor and mixed germ cell tumor. And non-germ cell tumor, as I told you, 5% is a non-germ cell, right? So 95% is a germ cell, only 5% is non-germ cell tumor. Statistically, only 5% is non-germ cell tumor, where there are mainly two things, leading and Sertoli cell tumor, right? Though they are not common, but you just need to know, right, for the exam point of view. So if they ask which of the following is not under non-germ cell tumor, then you must know it. And this is the absolute slide, very brilliant slide and very easy to remember as well, because this is complicated, but it looks, I try to make this, right? So seminoma and non-seminoma, right? So it is a part of germ cell tumor, which is 95%, as I told you, right? So 95% among seminoma is 40% and 60% is non-seminoma, right? Seminoma is localized to testes. This is extension to ear the testes and just above the testis epididymis, right? So it is extension of the epididymis, spermatic cord and scrotal sac, right? Extension to. So it is not just limited to testis. It is testis, epididymis, spermatic cord, right? And scrotal sac, which covers the testis, right? So this is locally advanced. Stage 1 and 2, it is usually diagnosed in early stage. And that is why it is a localized disease. This is 2, 3, and many a times 4. It is a metastatic or usually locally advanced at the time of presentation, right? Why it is a localized? Because the main metastasis is through lymphatic, so nearby lymph nodes, so lymph, right? So they are not metastasized. Here, from here, testis, it will go to paraaortic or inguinal lymph node, right? It can metastasize to lymphatic to local lymph node as well as hematologinous, means through the blood it can goes to lung and liver as well. So this is usually bad disease compared with the seminoma. This is localized disease. Localized disease you can treat with the radiotherapy and definitely with the surgery, high inguinal orchiectomy. And here, because of advanced disease, locally advanced or metastatic disease, you need to give chemotherapy, because radiotherapy and surgery is a local treatment, and right, and chemotherapy is a systemic treatment. So when the disease is beyond the testis to the lymph node, local lymph node, and or it may spread to the lung or it spread to the liver, right, you need to give something which controls testis, liver, lung, and that is why systemic chemotherapy is important. Prognosis is in general it is good and depends on the tumor type. So there are a lot of non-seminomas we have seen already. These are the uh, excellent explanation for basic things of seminoma versus non-seminoma. So you must keep in mind and the important clinically to treat the patient. And beauty, here is the beauty, here is the beauty. Let me show you the slide. So what is the beauty of testicular tumor, right? So beauty of the testicular tumor is this, the prognosis part. The overall prognosis of the testicular tumor is excellent, is excellent, is excellent. So don't confuse the patient when it comes to your OPD. Oh, it is a stage 4 metastatic disease. Even at stage 4 metastatic disease, stage 4 is the last stage, still it is curable. So high cure rate, 5-year overall survival is 95%. So this testicular tumor has an excellent prognosis amongst all cancer in the body, whether it is head and neck, lung, breast, cervix, colon, ovary, uterus, cervix, osteosarcoma, leukemia, lymphoma, myeloma, aplastic, blah blah, you name the disease. Testicular tumor has 5-year survival is the highest. It is the best, right? So always there is a hope even with the advanced disease. Even in advanced or metastatic stage, testicular tumors are oftenly curable, oftenly curable. So this is the beauty of this tumor. So even it is advanced or metastatic tumor, never ever lose the hope. It is still curable. And can anyone tell me, if we need a chemotherapy for testicular tumor, which chemotherapy is commonly we use? This all are the exam question. I am discussing one point, but there are related with the 100 points nearby. Right. So which chemotherapy? Can anyone tell me the name of the chemotherapy which can be commonly used? Right. So if you have non-seminoma, say for example, testicular tumor, you diagnose non-seminoma, patient has a stage 4 disease. Stage 4 disease means it goes to the liver, lung, probably the bone as well. You want to start the chemotherapy, systemic chemotherapy for this patient. What chemotherapy pick agent you gonna use for this patient? Anyone? Anyone has any idea? Fine, fair enough. So first line treatment is BEP. Remember this BEP. B stands for bleomycin. Remember bleomycin, right? E stands for etoposide, etoposide, and P stands for platinum or cisplatinum, cisplatinum. These are the standard first line regimen for testicular tumors. So BEP is the drug of choice. Now we need to see the bleomycin, right? Another exam oriented question. What's toxicity of bleomycin? Is pulmonary toxicity, right? So before starting the bleomycin for any patients, any indication, you must do the pulmonary function test or PFT DLCO. You must do it baseline before starting the treatment, because it has a significant effect on the lung. So if you have a bad pulmonary function test at baseline, you probably avoid this drug. Or if you have a good lung, but if the PFT is deteriorating after 1, 2, 3 cycle, either you need to adjust the dose of bleomycin or you need to hold the bleomycin. That's it. And platinum, there are ototoxicity, deafness. They have neuropathy, peripheral neuropathy, tingling, numbness, right? Ototoxicity, neurotoxicity, and worst is the nephrotoxicity. Nephrotoxicity. So you must have a good renal function test renal function test good, or you have a nice EGFR at least more than 60 EGFR, right? You need to know and read what is EGFR. Estimated glomerular filtration rate should is more than 80. Normal is more than 90 for your kind knowledge, but at least we should have a 60% or more than 60 EGFR before starting the cisplatin. So there are a lot of many questions, not just related with the disease, but it related with the drug side effects as well, right? So you need to know. And etoposide has a myelosuppression is common with this, right? So and rest I mean we don't need to know the general side effect like nausea, vomiting, constipation. It is there with each and every this chemotherapy, right? Every chemo. We need to know the basic. We need to know the specific side effects, right? Adriamycin, say for example, adriamycin specific side effect is cardiotoxicity. So we must know cardiotoxicity. We must know 2D echo and ECG. We need to do baseline before starting any and anthracycline or adriamycin drug or doxorubicin drug, right? So these are the few high yield points related with this. So I think I had given you the good idea about all testicular tumors, diagnosis, CT scan, tumor markers, no inguinal no biopsy at all for testicular tumor. High inguinal orchiectomy is treatment of choice. Tumor markers are important for the risk stratification and staging as well, right? And treatment and the take home message is this testicular tumor, even in advanced stage or metastatic, it is still curable. So that's all for the first question. If anybody has any questions, I would glad to uh, guide further. Is that clear to everyone? Yes or no? At least tell me yes or no.
Yes, sir.
Wonderful. Yes, Dr. Anisha, I think you are clear with the concept, right? I think you will not forget now.
Yeah, yes, sir. Now it is clear.
Wonderful,
Hey, very
brilliant. So we need to
informative. Very
understand.
informative.
Wonderful.
Yes.
Thank you very much. So we need to understand the concept for each and every MCQ rather than we mug up. So let's jump to the next questions. A young man is shot in the gunshot. Shot means gunshot. So a young man is a gunshot in the upper part of the neck with 22 caliber revolver. Inspection of the entrance and exit wound indicates that the trajectory of the bullet is all above the level of the angle of the mandible but below the skull. He is fully conscious, neurologically intact, a steady trickle of the blood flow from the both wound. It does not seem to respond to a local pressure. He is hemodynamically stable. Which of the following is most appropriate next step in the diagnosis? Clinical continuous observation because patient is stable, neurologically intact, so you can observe. Barium swallow, you are thinking some tracheoesophageal things are broken in the revolve wall, so you can do barium. CT angiogram you can do, endoscopy you can do just to make sure that there is nothing wrong in the upper aerodigestive tract, and surgical exploration because it gunshot wound, right? And local pressure does not help. This clue will not going to tell by anyone in your exam, but I'm giving you some clues so you can thought process would be little better. So local pressure does not helps to this patient, so you want to surgically explore. So now what exactly you want to do? Think of it for 10-15 seconds, give the perfect answer. Whatever the answer you give, A, B, C, D, E, I am happy. I will ask you only one questions, right? Irrespective of A, B, C, D, E, I will ask you only one question, and the question is why. If you say A, why? If you say B, why? If you say E, why? That's it. That is learning. Yes, Madhusha. Tell me, Dr. Madhusha. Now you are saying me surgical exploration. So why you want to explore patient surgically who is hemodynamically stable? Yes,
Mm.
Madhusha.
Uh,
Yeah, if you can able to speak up, you can speak up. No problem.
yeah.
Yes, please. So I
But
want to know.
blood blood flow is not responded to local pressure, sir.
Okay, fair enough.
It
One
will.
more questions. One more question. Do you know from where the blood is coming? From where the blood is coming? Which artery is bleeding? Right? And how it is feasible to explore surgically, right? The surgically the let me give you this chart, then your clarity would be there, right? So this is this chart, probably you have not seen a picture, sorry. Those who have not seen, I'll give you the idea. This is a gentleman. There are three zones in the neck, right? So first zone is a green zone, right? from where it start, manubrium sterni. This is a sternum, right? So this is sternum. So it starts from the manubrium sterni to cricoid cartilage. It is zone 1. From cricoid cartilage to angle of the mandible is zone 2. And from angle of the mandible to the base of the skull is zone 3. So out of this 1, 2, and 3, zone 3 is one of the most critical to access surgically. Hundreds of critical things are going. You don't know there is a bullet, there is an entry wound, and there is an exit wound. So this is entry wound you can see, exit wound you can see here, right? Continuous trickling of the blood is there, but you don't know from where the blood is coming, right? You press the things, but still blood is not stopping. Patient is hemodynamically stable. It is a beauty. Beauty is what? Hemodynamically stable. Hemodynamically stable, neurologically intact, right? So there is no urgency in opening this patient, right? First, you need to know from where the blood is coming. From where the blood is coming. So first find out the diagnosis. First find out the from where the bleeding starts. So, do you have any test by which you know that from where the blood is coming or where from where the bleeding is from this list? Can you do something and find out that oh, this is the bleeding site? Okay, fine.
CT
Yes, sir.
neck.
CT neck with angiography.
Wonderful, brilliant. So that is the answer. So CT neck with the angiogram, we'll see all rationals as well. So CT angiography, there are two things, CT plus angiography. It is two tests, right? Only CT scan of the neck is not a good idea, right? Because it will not give you good idea about the vasculature of the neck. Only angiography, it is more invasive, and angiography can be done at the second options, but CT angiography would be the best. It is a combination of CT scan, so complete whole CT scan of the neck. You can see whole the neck. So in all the whatever organs, aerodigestive, upper esophagus, cricoid, postcricoid, trachea, vessels, carotid, nerves, bundles, blah blah, whatever you want to see, you can see it with CT as well as the specifically arteriography or angiography. You can see the site of the bleeding, and beauty is that if you know the things, right, patient is surgical, hemodynamically stable, he will not die hopefully, right? And it is a small bleeding, right? It's not heavy. If it is a heavy bleeding, he will not hemodynamically stable. So site of the bleeding, once you know, you can give some injection in it and you can clot that as well with hemostatic agent as well. So this is a beauty, right? So whenever you don't know from where the bleeding is coming, you can do all these things from this same thing can be applied to the CT neck with angiogram, CT chest when somebody has a chest gun wound injury, right? You don't know from where the bleeding is coming, you do CT angio, right? If abdominal massive bleeding or rectum, you don't know, you need a colonoscopy, you don't find out, platelets are normal, PT, APTT normal, patient is fine, not on blood thinner, still you don't know where the bleeding is coming. You do CT abdomen angiogram. Is that clear to everyone? Yes or no? Right? So this is
Yes, sir.
how you can do it. And the next immediate step, first step is to do CT angiogram, CT neck plus angiogram. If you find well and good, right? If you can able to inject, right, it is good. After that, once you know from where, like where, which part of the neck, right, which for the zone it is bleeding coming, from where exactly it is coming, it is easy to explore. Is it easy rather than just blindly opening complete zone 3 and then oh you see blah blah blah, right? So if this patient answer will change, if I can only add two word here, this patient is hemodynamically unstable hemodynamically, then probably the surgical exploration would be the first answer. Local pressure does not help. Patient is unstable. You need to open as soon as possible, irrespective, even though high risk surgery, you need to ligate the vessel as fast as possible, especially unstable patient. This patient is stable, so try to find out the cause where the bleeding is coming and then you open up. Continue clinical observation. As I told you, our job is to rule out other continuous clinical observation is not a good idea because patient is bleeding. So would you like to wait and watch in any patient who is bleeding? Yes or no?
No, no, sir.
No. So continue clinical observation is not a good idea. I told you the reason why, because patient is bleeding, right? Barium swallow. Barium swallow. Why not barium swallow? Let me show you the picture again. So barium swallow is what it gives, give you the idea about barium swallow is exactly how and what you do. We need to know. You read each and everything, right? Try to push yourself a bit hard. It is very easy exam to crack it. Very easy, but we are not. So somewhere the here, right? So when you have a barium, so what you do? You drink a barium here, and you see the aerodigestive. You can see oral cavity, you can see cricoid, post-cricoid, here, esophageal stricture, blah blah. You can see barium. Here in this area, no esophagus coming. In this area, no trachea is coming. So bronchoscopy not help. Esophagoscopy not help. Barium will not help. Are you getting me? Yes or no?
Yes, sir.
Yes, sir.
Wonderful, wonderful. So this is you need to know what is the anatomy, right? So if you know the anatomy, then barium is not required, right? Because whatever, and we are not thinking of anything wrong here because injury is here, right? So no need to do the barium study for this, right? So continuous clinical observation is not a good idea in this patient, right? Because it is bleeding. So this patient, this is gone, barium swallow. Not worried about trachea, esophagus injury, endoscopy will not also help because we are in the zone 3 and this is in zone 1, so nothing to do. When problem is in zone 2, 3, why you want to do something in zone 1, right? It will not concluding. Surgical exploration is second most options after doing the CT angiogram. Is that clear to everyone?
Yes, sir.
Yes or no?
Yes, sir.
Yes, sir.
Wonderful, wonderful, wonderful. So this is beautiful picture just to bring the more clarity. And now look, gets back to the questions. They are not saying the zone 3, but this explanation is zone 3. Let's go back to the things. 22 caliber inspection of the entrance and exit would indicate that is the trajectory of the bullet above the level of the angle of the mandible. So this is angle of the mandible, right? So labor above the angle of the mandible, and this is a skull. This is a skull, right? So this is zone 3. From 3 here to cricoid 2, and from cricoid to sternal 1. Is that clear, right? So they have not mentioned clear cut zone 3, but it is zone 3, right? So we have seen, right? So what is they have mentioned exactly above the level of the angle of the mandible and below the skull. See it, right? So above the level of the angle of the mandible, above the level of the mandible, and below the skull. So it is zone 3. Is that clear to everyone? Yes or no?
Yes, sir.
Yes, sir.
Wonderful, wonderful, brilliant, wonderful. So end of the discussion is like it is a CT angiogram is the
Correct.
investigation of choice. Most appropriate next diagnostic step for a hemodynamically stable patient with a gunshot wound in the neck above the angle of the mandible is CT scan of neck with angiogram, that is CT angiogram, right? So this is very important, right? So we need to know. And last but not the least, why CT angiogram is preferred over conventional angiogram. As I told you already, in this case, the modern approach is to use the CT angiogram rather than conventional angiogram for the initial evaluation. CT scan without contrast versus CT angiogram with contrast. With a regular CT scan, right, shows the path is provided much less information about the vascular injury. The contrast enhanced CTA is crucial for the visualizing the extent of any vascular damage such as dissection, pseudoaneurysm, AV fistula, and blah blah blah. Right. So that's all for these questions. Any questions is there? I would happy to guide you.
No, sir, no.
Is that clear to everyone? Yes or no?
Yes, sir.
Yes, sir.
Yes, sir.
Yes,
Clear.
sir.
Wonderful. Next, jump to the next question. 31-year-old man is brought to brought by the helicopter to emergency room after motor vehicle accident in the which she sustained massive lower extremities crush injury. The patient is alert, awake, but is in tremendous pain. Blood pressure is 140 over 80. Pulse rate is 110 per minute. There is a copious ongoing blood loss from the site of the injury. Urgent laboratory data will most likely shows which of the following electrolyte abnormality and why. Hyperkalemia plus hypernatremia, hypoglycemia, hypokalemia, and one option I would like to add E is hyperkalemia plus hypocalcemia. Select one. A, B, C, D, E. Select one. Fifth option, keep in mind. Fifth option is there.
Sir,
Yes, you take your own
hyperkalemia
time.
is there. Hyperkalemia is there because of crush injury.
Right. So if you have to select one options, doctor, from the list A, B, C, D, and E. Select only one. Either you select if you want A, you select A. If you want to select E, you select E. You have five options.
Sir,
Once you
A.
select, then we'll discuss why. Once you select, we'll discuss why.
Option
Yes,
E, hyperkalemia plus hypocalcemia.
yes, doctor. So now let's discuss with you, if you don't mind, why you feel it is hyperkalemia with hypocalcemia. What is the
Um,
mechanism? How does it happen in this patient? What's the problem? So again, let's go back to the basic. What is the diagnosis in this patient? If you do this practice, you are in.
rhabdomyolysis.
Yes, doctor, please.
The diagnosis is rhabdomyolysis because of the crush
Rhabdomyolysis.
injury.
Wonderful. So yes, Alia. So I'll write down this is a crush injury. So it is a rhabdomyolysis. What happens in rhabdomyolysis? What is basically rhabdomyolysis means what?
There is a damage to the muscle because of which the potassium increases.
Okay, so muscle damage and potassium is increasing, right? Fine, fair enough. And how does the calcium goes down? What is the mechanism? Why calcium is going down? This is
Um,
perfect. This is perfect. You understood, your concepts are clear. When there is a crush injury, right? Crush injury, there are muscle crushed, right? So this is muscle, skeletal muscle. So it is an intracellular component within muscle. There are lots of potassium. So this muscle, when injured, damage, it goes into the blood, right? Circulation. And from muscle, it goes to the blood, and there is a hyperkalemia. It increases in the blood. So it is hyperkalemia. So this is perfect, right? What is the mechanism of hypocalcemia?
mm, I'm not very sure how it
Fair
happens.
enough, fair enough. I'm happy. At least you are discussing with me. I'm happy. And you never ever forget now when you discuss any topic because it stick to the head, right? Anyone wants to comment why hypocalcemia also there? We understood that there is a crush injury, lots of potassium released from the blood to the systemic circulation, hyperkalemia. That's it. Why hypocalcemia? Anyone?
Sir, there is an hyperphosphatemia, so calcium may
Hyperphosphatemia,
bind
probably it binds this calcium
with
binds
the
with the
calcium.
phosphorus. So that is one mechanism, right? So answer for this, right? So answer for this is a hypercalcemia with hypocalcemia is the things which we can see it, right? So let's little deep dive into the understanding of this, right? What happens here very quickly, as Dr. Saleh already told perfectly, why hyperkalemia? So and massive lower limb crush injury, most likely electrolyte abnormalities are hyperkalemia and hypocalcemia. Patient arriving in with this injury will most likely show urgent laboratory data like this: hyperkalemia and hypo. Why hypercalcemia? First, we see that massive cell death. Massive cell death. Crush injury causes widespread damage and necrosis to the muscle. Right, condition called as a rhabdomyolysis, rhabdoskeletal muscle myolysis means death of the muscle, breakdown of the muscle. Since potassium is the most abundant intracellularly in the muscle, the destroyed muscle cells releases large amount or quantities of the potassium into the blood, and that is why that is hyperkalemia. Is that clear to everyone? Yes or no?
Yes.
Right. This is one. On our patient, this is the mechanism. There are two other things. If you have a renal functions impaired, maybe chronic renal failure, you see a lot of patients with hyperkalemia because potassium is not excreted from the urine, so hyperkalemia and acidosis can also cause the hyperkalemia. So if you want to treat the hyperkalemia, you look for all the three things conditions, right? Now let's check the why hypocalcemia. What is the reason behind the hypocalcemia in the hyperkalemia patient, right? So this is the theory: calcium influx into the cell. So what happens? Calcium influx. So this is a cell. Potassium is going out of the cell, right? And there is an influx of calcium. So one is increasing, one is decreasing. The same damage that causes potassium to leak out of the cell also allow extracellular calcium to flow into the damaged cell through leaky membrane. Leaky membrane. Is that clear, Dr. Saleh? Right? So this is the one
Yes,
thing, right?
doctor.
Calcium phosphate complex formation. This is second thing. Breakdown of the muscle cells also releases large amount of intracellular phosphatase, as some doctor told already. This phosphate can bind with the calcium phosphatase, and this calcium will reduced in the plasma. That's it. So the breakdown of the muscle cell also releases large amount of intracellular phosphate. This phosphate can then bind with the precipitate of calcium, circulating calcium, forming calcium phosphatase crystal that can also deposit into the damaged tissue, and this further reduces the calcium in the bloodstream. Is that clear to everyone? Yes or no?
Yes.
Wonderful,
Yes, sir.
brilliant. So this is what the thing is. So our answer is done so far. Our answer for this point of question. So my one job is done. What is the happening here? So I will later on add here one more option. Hypokalemia with hypocalcemia. We need to know. So we need, right. So we did a diagnosis. Diagnosis is rhabdomyolysis. Electrolyte abnormalities, hyperkalemia with hypocalcemia, right? Second question, what are the EKG changes seen, electrocardiogram changes seen in hyperkalemia, right? Let me draw the normal ECG. This is P wave, which represent the atrial activity, atrial depolarization. This is small q wave, this is R wave, this is S wave, and again this is the T wave. So P, Q, R, S, and T. So I want to know what happens to P wave. I want to know what happens to QRS, and I want to know what happens to the T wave in hyperkalemia. I need one volunteer who can answer all these three. Yes, anyone. All exam questions. Don't take it. Whatever form it comes, it comes. But it will 100% comes. So our job is not just to know the things. This all are high yield we are discussing now. Yes, anyone, Dr. Saleh, do you know what ECG, EKG changes you can come across, or do you have any idea of EKG changes in hyperkalemia, which is very high, very common in clinical practice as well as frequently
It is
asked question in
tall,
exam?
tall tented T waves.
Tall tented T waves. Wonderful. So you did one excellent job. What happens to T? Now tell me what happens to P and QRS. This is perfect.
Widening
Brilliant.
of QRS.
Widening of QRS. Wonderful. This is also job done. Wide QRS usually. What happens to P wave? Because we need to know if they, you know, T wave, but they ask what happens to P wave, then you also need to know, na? Otherwise you lose the one wrong. Yes, so the many a times you see flattened T wave, flattened T wave, right? So this is three things you need to mug up: flattened T wave, QRS wider, tall T, tented wave, or very high. So I will show you the pictures as well. Don't worry, don't get confused, right? So I have everything ready for you from the journal, not in the routine books or master the board. I do a lot of exercise before presenting, so to make your life easy. So this is hyperkalemia, means high potassium level in the blood, right? When there is a moderate high, means less than 6, 7, prolonged PR interval, flattened P wave. So what happens to P wave? Is flattened P wave. And PR is prolonged, QRS is wide, PR prolonged. And severe wide QRS. And this is peak T wave. So you can see the peak T wave. So T waves is supposed to be like this. Instead, what you see here, T wave. It's like double QRS, like double QRS, even taller than this. So peak T wave, right? So T wave is peak. right? So, and small or the P wave is almost flattened here. So these are the classical signs. So P wave is flattened, PR interval is prolonged, QRS is widened, and tall T wave. Is that clear to everyone? Yes or no?
Yes.
Yes, sir.
Yes, sir. Yes, sir.
Dr. Saleh, is that clear to you?
Yes, doctor. Very much.
Wonderful, wonderful, brilliant. So now what we jumped is the diagnosis, then electrolyte disturbance, EKG changes, and last but not the least is the treatment. So let me ask you the question in that sense that you have a one patient, same patient. Let me go in this scenario, right? Right? Electrolyte abnormalities. Patient potassium, patient potassium is 8. How you treat this patient? Same question, I added 2 lines. Now you did the blood workup, there is a hyperkalemia, right? Now you supposed to treat this patient. You supposed to treat the patient? Give me the all 5 classical points, 1, 2, 3, 4, and 5. These are the minimum points you need to know each and everything, right? So what is the first and foremost? An EKG of this patient is showing tall T wave. That is also I'm giving you the clue, tall T wave, as you rightly said, right? So this is a hyperkalemia patient, level of potassium is 8. You did a ECG showing tall T wave. How you supposed to treat or manage? What is the number one? What is number two? What is number three, number four, five? I need to do and know exactly as per the guideline. Anyone, Dr. Saleh, do you have any idea about treating or have you ever treated this hyperkalemia in your practice?
I haven't treated, but looking at the case, I think because there is a um blood loss, so first we correct the hemodynamics by giving fluids.
Fair enough. So ABC is taken care of. Okay. You secured and maintain airway. Breathing is taken care of. Circulation is fine. Patient is not much, I mean, in stress. Patient conscious, well oriented. Blood pressure is good. So he is not in shock, right? It's fine. No? 148 is
Yes.
a good. Maybe because of apprehension, anxiety, he may have some kind of tachycardia, right? That's fine, right?
Yes.
So now ABC,
And
you taken care well. Okay, fine. Patient airway is secure and open. Patient is breathing well. Patient pulse, volume, right, is regular. Rhythm, volume is good. Everything is fine. Heart sounds are good. No murmur, nothing abnormal. Everything is okay in cardiorespiratory and neurological system. Now, how you want to treat this patient? This is the question. Now I
Sir,
think you have all the
hyperkalemia
details.
sir.
Sir, IV calcium
Calcium
chloride.
gluconate.
One by one. Sorry. Yes, Madhusha, you tell first. Madhusha.
Yes, sir. In hyperkalemia, first we have to stabilize the cardiac muscles. Start calcium gluconate
Very
as
good. So
cardiac
calcium
stabilizer.
gluconate or calcium chloride. Dr. Saleh, why we are giving the calcium and gluconate and calcium chloride, right? When they are not reducing the potassium, why we are giving it? Because we want to reduce the potassium and calcium chloride and calcium gluconate not at all reduces the potassium. Then why we are giving it?
um, I think it's because the channels involved, the potassium and calcium, the exchange channels, because of
Fair enough, I understood channel, but what happens? What happens if you don't give calcium chloride and gluconate? What happens? Somebody told, sir, give calcium gluconate or calcium chloride. Either of this one you can use. Why you want to give? Because it is not
Good.
going to change the potassium. Potassium, if you give calcium chloride, it will aid potassium. If you don't give, it remains the 8. Then why you want to give? The biggest
So
thing is that,
due to
yeah,
hyperkalemia, maybe there are cardiac arrhythmias.
wonderful, Sidra. So there
It
is a cardiac
stabilized
arrhythmia.
myocardium.
So there is a VT, first of all VT, that is ventricular tachycardia, then ventricular fibrillation, and next immediate step is the death for hyperkalemia. So it is a medical emergency like acute myocardial infarction. So if you have two patients in your OPD, acute myocardial infarction and hyperkalemia patient with potassium of more than 8, I will treat the priority to both the patient He will die because of coronary blockage, VTVF. He will die because of VTVF. He also die because of VTVF. So you cannot ignore that, oh, potassium is nothing to worry. You go ahead, treat acute MI patient first. He will eventually die. He probably die faster than acute MI because high potassium increases the cardiac excitability. It causes the fatal arrhythmia, VT and VF, right? And that's to prevent that, we are giving calcium gluconate or calcium chloride. Why I wrote both? Because if they, I'm telling you calcium gluconate, but they give exam calcium chloride, both are same thing. Give calcium, that's it. What happens? It will stabilize the cardiac cell membrane and it prevents the fatal arrhythmia. So now you are secure by giving the calcium gluconate and calcium chloride, that hopefully he will not die now. You had given the calcium gluconate and chloride, right? I'm not going in detail how much is the dose, at what infusion rate you give, how repeatedly you give. It's later on, we'll discuss. It's all clinical. But you at least must know, right? Being a clinician, I need to know. I have many patients who have a leukemia, lymphoma treatment coming to me, and I'm giving chemotherapy. There is tumor lysis syndrome. And in tumor lysis syndrome, biggest thing is hyperkalemia and hyperuricemia. So I need to take care of this. I need to take care of this for this purpose, for this purpose. So I need to know calcium gluconate I had given, no response, then what I supposed to do? What I suppose. So we'll discuss that later on. But anyway, for exam point of view, you need to know calcium chloride or gluconate. So your cardiac part is taken care. Now, second job is to reduce the potassium from the blood. Are you getting me? Yes or no? Yes or no?
Yes, sir.
Yes, sir.
Two ways, two important things, right? Glucose insulin drip, we call it as a GI drip or glucose insulin or dextrose insulin drip. People are saying, sir, why you want to give glucose and insulin, both the things? It will not neutralize. So let me give you the basic concept, right? Now this is cell and this is a blood vessel. So potassium is here too much in the blood. So by giving the insulin, if you give the insulin, right, what it does, insulin, it influx the potassium from blood to the cell. Again, it pushes back from the circulation to the cell, intracellular component. But same time, what happens? Glucose is also there in the blood. So along with the potassium, glucose is also going into the cell. So there is a hypoglycemia in the circulation. So patient may have hypoglycemia. And to avoid hypoglycemia, we are giving glucose. Is that clear to everyone? Yes or no? At least tell me why yes or no. So ideally is the
Yes, sir.
insulin drip,
Yes,
but
sir.
to avoid the hypoglycemia, we are adding insulin plus glucose. That's it. So this is right. So you are reducing this. So this is number one after calcium gluconate, number one GI drip, right? Number two after GI drip, you can use also SABA, short acting beta agonist, that also increase influx the potassium to the cell. Fourth is a binder that is a potassium binder, right? Or chelating agent, potassium chelating agent, right? So there are many K bind or potassium bind sachets are available in the market. You can give it. And if all fails, GI drip does not work, SABA does not work, binder does not work. Last but not the least, hemodialysis is the fastest treatment which reduces the potassium from the blood. That's all from my side. Is that clear to everyone? Yes or no?
Yes, sir.
Yes,
Yes, sir.
Yes.
Dr. Saleh, hi. Are you clear with this?
Yes. Yes.
Wonderful. Any question with this?
No, doctor.
Wonderful. So this is all concept we are understanding. What exactly we are doing in hyperkalemia. We don't need to mug up. So hyperkalemia is one of the deadliest bad medical emergency, right? So you need to know how you diagnose. You need to know what is the criticality. You need to know what are the EKG changes, and you need to know what is the treatment, right? So if you diagnose, but if you don't treat on time, they will die. So it is absolutely important to understand and know. So this is management, immediate management. I told you, stabilize the cardiac membrane, shift the potassium to intracellular, remove excess by chelation and dialysis, and long term you need life dietary changes, restrictions, drugs, and try to treat the underlying cause. That's all from my side for hyperkalemia, right? So we understood all well, right? I'm not going much in detail and switch to the next question. 52-year-old man has been important ever since he had abdominoperitoneal resection for the cancer of rectum. Tumor was stage as T3, N0, no node involvement, M0, no metastasis, distant. He gets no nocturnal erection and his importance extend to all situation, regardless of sexual partner, and includes the inability to masturbate. Is erectile dysfunctions likely due to damage of which of the following? Arterial vascular insufficiency, erectile dysfunction, now damage, psychogenic factor for this patient, tumor invasion of the urethra, venous incompetence. So first of all, you think over the answer. Meanwhile, I'll post my things. This is beautiful. Try it again. Without diagnosis, you can't jump on the treatment. So you need to know three things for each and every MCQ. So before answering me, diagnose me. What is the problem? What is the diagnosis? If you know this first step in any MCQ, your 90% job is easy by my experience. Always ask three things to yourself while you are preparing for MCQ. Brings lots of clarity. Yes, anyone, open for all. Dr. Anil Bishnoi, any comments sir, on this topic?
Sir, I'm just reading the question.
Sorry, sir.
I'm reading the question.
Yeah, you take your time. I am not in hurry. You read, right? Reading will take 15 seconds, so you read it. Yes, Dr. Ganiat, any comment? Yes. Anyone? Yes, okay. She is saying B. Yes, Dr. Saleh, what's your comment? Dr. Anisha, what's your comment? Lalit, our old player. Yes, Lalit, welcome. Dr. Sandhya, what's your comment? Dr. Purnima, what's your comment? Purnima.
Sir, it could be B, erectile nerve damage.
Okay, so what exactly erectile nerve damage means? Is that the name of the nerve is erectile nerve damage, or is there any specific name of erectile nerve?
I don't know, sir.
No problem.
Maybe he was
Any,
operated. Maybe there is some
sorry,
certain.
sir.
Maybe the patient was operated, or some nerve might have damaged.
Fair enough.
Wild guess.
Okay. 1 minute. I'll just make the mic mute for everyone because a lot of background noise. Those who wants to interact, just open up your mic. I muted all. Okay, so one answer is erectile. Yes, Dr. Saleha. Any
Cavernous nerve,
comment?
I guess. Cavernous nerve, sir, involvement, I guess, sir.
Okay, so your homework, everyone homework is to know which nerves are coming nearby the rectum. Right?
Pudendal nerve maybe.
Fine. So read it and post it in the group. Fine, fair enough. So answer for this is erectile nerve damage, right? So erectile nerve damage, this is not a vascular, the erectile dysfunction is likely because of erectile nerve damage. The total absence of both nocturnal and situational erection point towards the organic problem specifically rather than neurogenic one, right? So a well-known risk factor for abdominal perineal or APR, shortly we called in oncology is APR or anti-abdominal perineal resection is damage to a erectile nerve as a rectum is widely dissected because this patient has T3N0M0. So it's a large tumor. T1 and T2 is better than T3. So T3 is a large tumor, extensive it already. So you need a larger dissection, and in that case, you probably damage the nerve. 50% of the incidence of post-operative importance is commonly quoted, and that is what being a surgeon or oncosurgeon they have to explain to the patient while they are doing the wide dissection in the rectum. You probably have importance, right, or erectile dysfunctions, right? It is a very important side effects, right? So now sparring surgery can be done, right, if the dissection is close to the rectal wall, especially tumor is less than T3. So this is T3, you need a wider dissection, and because of that, you may have high chance of damaging the erectile nerve. That's it. So this is what the thing is. Now jump to the next question. So go and read rectum. What is abdominal perineal resection or APR? It is very commonly asked question. One of the commonest malignancy, top 10 malignancy in India and Western world as well. Right? Colorectal cancer. We call it as a colorectal cancer. So another question, 56 years old man present to his urologist for continued evaluation of hypertension and hematuria. The patient had a 10 years history of hypertension and the recent onset of painless hematuria, for which he sought the attention of a urologist 3 months ago. On detailed questioning, the man states that he is having a severe headache that are refractory to narcotic analgesic. 3 days ago, the renal ultrasound was obtained that demonstrated bilateral enlarged kidney with multiple cysts. Which of the following is most appropriate next step in the diagnosis? CT scan of pelvis and abdomen, CT scan of chest, intravenous pyelography, MR angiogram brain, none of the above. What is the diagnosis and how you supposed to treat it? Post your answer. Yes, Dr. Anisha, what do you think? What is the diagnosis in this patient? What's the diagnosis? Yes, Dr. Anisha, any comment?
This time reading the questions.
Fair enough.
Sorry.
Meanwhile, I'll ask to doctor. No, carry on. You need to speed up in the exam, doctor. You hardly get 1 minute for one question. Yes, Dr. Sabnam, what do you think?
Sir, I think it's polycystic kidney disease.
Okay, polycystic kidney disease. How did you get to know this is polycystic kidney disease?
Sir, because here the ultrasound demonstrates bilateral enlarged kidney with multiple cysts.
Wonderful, brilliant. So at least you reach to the diagnosis that, okay, bilateral polycystic kidney disease. All right. So
Yes,
in
sir.
polycystic kidney disease, why you want to do the MR angiogram? Why you
Sir,
don't want to
because
do
of
the
the
pelvis ultra?
brain this aneurysm that it can lead to.
Okay, fair enough. So you are thinking that polycystic kidney disease, right? They may have also the brain aneurysm as well, right? In the brain,
Yes, sir.
there must be some aneurysm in the vessel, right? That is what you are
Yeah.
thinking, right? And
Yes,
that
sir.
is bleeded, and that is why refractory headache, isn't it? Yes or no?
Yeah.
Refractory
Yes,
headache,
sir. Yes,
right?
sir.
Refractory word, refractory, the literal meaning of
Refractory to
refractory means
narcotic analgesics.
refractory means not responding to
Yeah.
narcotic even, not
Yes, sir.
responding. The medical fancy word is a refractory, right?
Yes, sir.
Refractory means not responding.
Not responding.
Somebody has 104 fever and paracetamol not working. So we can say paracetamol refractory, not
Refractory.
responding to paracetamol. Is that clear?
Yes,
Right?
sir.
So here the answer is absolutely right. MR angiogram brain, you need to do it, right? Because for two things, he has a severe headache, so probably there is a bleed, right? And MR angiogram is important. CT scan of pelvis does not help because you already make a diagnosis: autosomal dominant polycystic kidney disease. ADPKD is the complete. We are not dealing with anything, and polycystic kidney disease, they have high incidence of cyst, those who have polycystic kidney disease. So primarily it is disease in the kidney, multiple cyst. Along with this, they may have cyst in the liver, cyst in the brain, not much cyst in the chest. Is that clear? Patient already have neurological symptoms. So priority is to do the right, not the abdomen, not the chest, right? Priority is to do the brain. CT, MR, angiogram, brain. If it is bleed, then you have to stop it. Intravenous pyelogram is not at all important in this case. We are not dealing with anything, something stone or something, not thinking of that, right? So MR angiogram is extremely important. What the literature shows, and it gives the idea. Let me go through the literature quickly. So most appropriate next step is to do the MRI angiogram. The combination of long-standing hypertension, bilateral enlarged kidney, multiple cysts on the ultrasound, and severe refractory headache strongly suggest the diagnosis of polycystic kidney disease. AD means autosomal dominant polycystic kidney disease is associated with increased risk of intracranial aneurysm. So what I suggest to those who have polycystic kidney disease, even they don't have a headache, I strongly recommend it clinically to go for MR angiogram, right? Don't wait for the symptoms or the headache to occur. They will die suddenly because when they rupture, all of the sudden they massive bleeding, they collapse. So every patient of polycystic kidney disease must go for the MR angiogram baseline just to get the know. I told you there is a there is a cyst in the brain, right? Cyst in the liver as well as in the brain. Cyst is called aneurysm, right? Vessel cyst or aneurysmal, intracranial aneurysm. So this is normal vessel, just for your knowledge. This is normal vessel. What is aneurysm? This is blood vessel, but there is like a balloon, wall is thickened, wall is thickened. So this is a thin wall. When there is a hypertension, right, this is easily gets ruptured and there is a brain bleeding or intracranial hemorrhage, right? So you need to do clip surgery. You need to, right, you need to clip it, right? You need to do coiling here so it will not rupture and patient will survive. So this is job of neurosurgeon. They will do it in our hospital regularly, clipping and all for aneurysmal surgeries. So AD, PKD, right? So patient symptoms, ultrasound findings are classical, right? Genetic disorder, right, in the kidney and other organs means brain and liver commonly, right? Intracranial aneurysm most common in people with polycystic kidney disease with high risk, those who have hypertension. So this patient has hypertension. If you read our patient has hypertension, our patient has hematuria. So because of hematuria, people are confused for the CA bladder and they opted the options of CT scan of abdomen pelvis, right? So we are not worried about this. This is classical polycystic kidney disease. Just to confuse you, they have posted the uh, this hematuria, right? Severe headache. Now, new onset or unusual severe headache, especially those refractory to the analgesic, can be warning signs of expanding or leaking intracranial aneurysm, and this warrants immediate investigations. An MR angiogram is the preferred non-invasive method for screening and diagnosing IA in patients with ADPKD. It visualizes the blood vessel in the brain without needing contrast agent that could be further damage to the kidney. Given the patient's severe headache, a brain aneurysm must be ruled out immediately. It could be tension headache, it could be cluster headache, it could be other headache, it could be hypertensive headache. But what you don't want to miss is the aneurysm in the brain, which will fatal shortly. Is that clear to everyone? Yes or no? Yes or no?
Yes. Yes, sir.
Yes, sir.
Wonderful. Brilliant. So I think concept is clear, right? Now, wonderful. Fortunately, I got a brilliant people around me. Wonderful. Maybe easy questions for many people. 8 months old baby presented with history of recurrent crying with on and off jelly stool. The diagnosis is intussusception, intestinal obstructions, Meckel's diverticulum, strangulated hernia. Yes, post your answer in the chat box or you can open up the mic and speak.
Sir, it's a intussusception.
Yes, Saleha. Tell me, Saleha. So, what is
Intussusception, sir.
intussusception?
Intussusception is the telescoping of one part of the
Yes, telescoping of what?
one part of
Lumen.
a lumen into another
Okay,
lumen, like
fine.
in colon.
Fair enough. I got your concept. So, this is telescopic, right? Telescope. We have seen that this is the eye of the telescope. So, this is a small part, right? And again, a big part, right? This is telescoping. And this is likely an intersection. We are seeing it from here to the far area. So, telescopic, these things. Fair enough. How you investigate, how you suspect that this patient has this patient, what are the presentation of the intussusception? How usually patient present with the intussusception? What is the
Sir,
commonest age?
sir,
What is the commonest age for the intussusception? What is the presentation? What is the best investigation of choice for intussusception? And what is the treatment as well? Because our triad we never missed. What is the diagnosis? So you told diagnosis is intussusception. So how you supposed to investigate? What is the initial and based investigation? And what is the treatment as well? So how you supposed to manage?
Sir, at around 6 months to 10 months, at that time, the presentation and the baby will present with an incessant cry, and I may be associated with the recurrent jelly stool, red jelly stool.
If I want to tell, do the radiology, which radiology you do? Which is the best
Sir,
investigation of the
ultrasonography will get the donuts.
donut sign? Ultrasonography will see the donut sign. Okay, fine, fair enough. Anyone else? Dr. Saleha, what radiological sign you suspected the
And
patient as an
enema?
intussusception?
CT scan, sir.
What is a yes? Yeah, yeah, you go ahead. I'm listening.
Ultrasound
CT
no
scan.
scan.
Right. So which radiology? You do X-ray, you do sonography, you do CT scan, you do MRI, you do this enema. What you do for this patient? What is the initial
CT scan, sir.
investigation?
CT
CT
scan.
scan. Directly you want to do the CT scan.
No,
Uh,
ultrasound.
we do ultrasound first. We see that bull's eye sign,
Which sign, sir?
bull's eye or target sign in ultrasound.
Bullseye. In ultrasound, you can able to see it, target sign, or I will confuse you. You don't confuse. I will confuse you. You don't confuse. You stick to your answer. You are going right. You are going very well. Excellently going. Yes. So ultrasound sign includes target sign, or also known as a donut sign. Target sign or donut sign. You need to know. You don't need. We don't need to just know the intussusception. This second question will be this, right? Or it may ask target sign or donut sign is seen in which condition. Then the answer is this intussusception, right? Then pseudo kidney sign. It looks like a pseudo kidney, and crescent in a donut sign, crescent in the donut sign. So these are the few signs you can see in the ultrasound, right? So that is also important, right? CT scan is more sensitive and specific, but as usual, whenever you have ultrasound, you do it. It is a first investigation, easily available, cheap, good sensitive specificity. If inconclusive or equivocal, you may ask, right? So if they ask specifically which test has the highest sensitivity and specificity, then answer would be CT scan. Otherwise, ultrasound is good enough to start with, because these are the few arbitrary line. It's like a vague line between how to answer and what to answer, right? Based initial test and based confirmatory test, answer may change. Acute myeloid leukemia, based initial test, CBC peripheral smear. Most confirmatory test, immunophenotyping. See the word change, the answer change. Based initial test, acute myocardial infarction, ECG enzyme. Based test to diagnose coronary angiogram or PCI. Answer will change, right? So you need to know, you need to do practice in everyday in and out, that how you supposed to answer, and for that you need a good understanding of each and every MCQs, right? That is very important. Okay, anything else in the intussusception? You diagnose the intussusception with a clinical history, examination, donut sign, everything is classical. How you supposed to treat this patient? Let me ask you the treatment best treatment of
Enema.
the intussusception, Saleha.
Enema, sir.
Sorry,
Enema.
enema. Which enema?
Enema.
Water enema, drug
Aero
enema,
contrast
air
enema.
enema? Which enema?
Aero contrast enema.
Which enema? Sorry, doctor.
Aero contrast enema.
Air or contrast enema. Okay, fine. Anyone else? Fine. So fair enough. So
Saline reduction.
intussusception is sorry.
Saline reduction.
Yeah, the better answer is intussusception is treated with either by two things. One is enema, right, and another is surgery. If you does not improve with the enema, you need to switch to the surgery, right? Non-surgical
Yeah.
approach use an air or liquid contrast enema too. In enema too, either air or non, right? Air enema or liquid contrast enema, which can both diagnose as well as the treatment of condition, right? So that is the most important thing. So air enema or this liquid enema, contrast enema you can give, which is diagnostic as well as therapeutic. And if does not works or no improvement of the symptoms, then obviously surgery would be the next appropriate answer, right? So, and it is only is required if the enema is unsuccessful. So you conservatively air enema, liquid enema, if does not improve, go for surgery. Is that clear to everyone? Yes or no?
Yes.
Hello.
Yes, sir.
Yes, sir.
Yes, sir.
Wonderful. Brilliant. Brilliant. Right. So our job is not just to know the answer. We need to know three things in triad. This is intussusception, telescopic things, right? Peristalsis, intussusception. The one intestine goes into the another intestine. The excellent, brilliant picture seen on the left side, right? Intussusception picture. And here the baby is sitting. This is a normal intestine on the right side, right? And this is intussusception. So once you give the enema, well, you give the air or liquid, it will open up usually, it will reduce it. If not, then you have to do the laparotomy. That's it. So this is what the thing is. So would like to discuss one or two more questions. Are you okay with that? Yes or no?
Yes, sir. Yes, sir.
Yes, sir.
Okay, sir. Okay. Rest.
Brilliant. Brilliant. The patient was diagnosed with severe acute pancreatitis and gives you a biochemical value which shows low albumin, high amylase, lipase, mild increase in liver enzymes. And now, this severe acute pancreatitis patient, you want to give the nutrition to them, right? So, what type of nutrition you supposed to give to this patient of severe acute pancreatitis? Total parenteral nutrition based. You give the rest to the GI tract. Parenteral glucose diet, low protein and high calorie diet, or nasojejunal feeding.
D, sir.
Okay, your answer is D. Let me check with other expert as well what they wants to comment.
Yes, sir.
Okay. Yes, Dr. Purnima, I want to hear from you. Dr. Jinu,
Parental nutrition we give, sir, but if a patient cannot take, then we go for nasal tube feeding.
fine. So, what is the answer for this? Should I take A or D for you? If same question comes in the exam, what you take? And obviously, when you
A,
take A
sir.
or E, I will ask
A,
A.
sir.
So, Dr. Purnima is
A.
saying A. Okay. So, now another question is why A? Why not E? Why not E? Why not D? Sorry, E is not the option. You are saying why? A, but I am saying I want to give nasojejunal. So now you need to know what are the advantage and disadvantage of nasojejunal feeding versus total parenteral nutrition, isn't it? Yes or no? At least tell me yes or no.
Yes,
Yes,
yes.
sir. Yes, sir.
So which one is more beneficiary to the patient, total parenteral nutrition or nasojejunal feeding? Or what are the indication of nasojejunal feeding? Yes, Purnima. What are the indication of nasojejunal feeding? Very important question. When you supposed to decide that okay, I don't want to give oral, I don't want to give enteral, I don't want to give nasogastric, I want to directly go nasojejunal, no nasogastric or Riles tube, nasojejunal. So is there anything or is there any indication where you supposed to give nasojejunal bleeding to the patient, or what are that condition, Purnima?
Esophageal carcinomas.
Okay, so esophageal carcinoma, where you want to give. So in esophageal carcinoma, you can give the nasogastric, na? You bypass the esophagus. Why you want to give nasojejunal? Because cancer is like in the esophagus, not in the stomach or duodenum. Then why you want to put long tube up to stomach, duodenum, and then jejunum? You understand my question, Dr. Anil sir?
Yes, sir. Yes, sir.
Yes.
Wonderful, wonderful,
Maybe
wonderful.
it's
Maybe for jejunum, we are providing for jejunum maybe to stop the peristaltic movement of the esophagus, and because of which I think the pancreas don't work, right?
Fair enough. So answer is nasojejunal feeding. Dr. Purnima, it is not a total parenteral nutrition. I will give you the reasoning as well, and that is the learning. So TPN is not the treatment. Nasojejunal feeding tube insertion. So see, this is the nose. It started from the nose, right? And it enters, it's going here, nasojejunal, right? sorry, this is esophagus, stomach, duodenum, and up to jejunum. It is going up to jejunum. So it is, if it is going from nasal to stomach only, it is nasogastric. Start from nose, going up to the gastric or stomach, or nasostomach or nasogastric, nasostomach or nasogastric, and then nasojejunal, so starting, entering from nase and going up to the jejunum. That is called NJ tube. Right tube is called NG tube, nasogastric. Are you getting me? Yes or no?
Yes, sir.
Yes, sir. Yes, sir.
Wonderful, brilliant.
Yes.
Indication, inability. Dr. Purnima, listen, inability to feed orally. So when patient does not able to take it orally in any condition, right? Any condition. There are 100 long list, right? Which are the condition where patient cannot take orally? Hundreds of reason. Cancer, trauma, malignancy, oral cavity, blah, 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 long list. Anyway, but this is basic. Unable or inability to feed orally. Patient who are unable to consume adequate nutrition orally due to conditions such as dysphagia is in the esophagus mainly, right? Neurological disorder, neuromuscular disorder, multiple sclerosis, or any other neurological, impaired gastrointestinal motility, right? Where you have no normal peristalsis, no need to give oral. Second is gastric intolerance. Patient experiencing gastric intolerance or feeding related complication like aspiration, reflux, or persistent vomiting, right? Try to avoid, right? So in that case, don't do the oral, go for this. Gastric intolerance, go for naso. So nasojejunal one orally is inability to take orally, one indication, many condition, right? They are able to take orally, but gastric intolerance, don't give, right? And jejunal feeding is required specific medical condition or surgical intervention, gastric bypass surgery, pancreatitis, critical illness that necessitate the feeding directly into the jejunum. So these are the few excellent important indication for nasojejunal feeding. And before that, I would like to also clarify why not. That is the questions of Dr. Purnima. So these are the head-to-head comparison, and there is a literature for severe acute pancreatitis. The preferred nutritional support is early enteral nutrition, no parenteral, no parenteral or TPN, no parenteral. Enteral means which goes from the mouth going to esophagus, stomach is the enteral. Enteral means GI tract, no and non-enteral, right? So we don't need to give parenteral. Parenteral means systemic. Out of the GI tract is parenteral. Out of the enteral is parenteral. So we want to give enteral through the mouth. It goes through the mouth and stomach, natural way. So severe acute pancreatitis, the preferred nutritional support is early enteral nutrition via nasojejunal feeding, via nasojejunal, not gastric feeding, not total parenteral nutrition. Rational why you want to give the enteral or nasojejunal is enteral basically, right? So superior to total parenteral. Dr. Purnima, this point will clarify your concept. Why not TPN? Superior to TPN means total parenteral. Every extensive, not small, extensive evidence from the systemic review and meta-analysis means multiple site. It is meta-analysis has shown that the enteral nutrition is superior to TPN, or enteral is better than non-enteral in patient with severe acute pancreatitis. How? Number one, it reduces the complication. Which complication? Compared to total parenteral nutrition, enteral nutrition is associated with the significant lower rate of mortality, means death, multi-organ failure, systemic infection or septicemia, and surgical intervention. Dr. Purnima, are you getting me? Yes or no?
Yes, sir. Yes, sir.
Wonderful. So this is the reason, because the morbidity is less, mortality is less, and most important, the infection systemic, because total parenteral nutrition is going continuously to the patient, and it increases the significant risk of systemic infection, gram positive and negative, and that is why we are avoiding it. And enteral nutrition is best than the parenteral nutrition. Is that clear to everyone?
Yes, sir.
Yes, sir. Yes.
Sorry, doctor.
Yes, sir.
Wonderful. So the answer is the total this nasojejunal feeding or enteral, not the total parenteral nutrition, or parenteral nutrition is not good, right? So last but not the least, the rationale or summary or recommendation for acute pancreatitis, right? So whenever you admit the patient of acute pancreatitis, prioritize the enteral nutrition, not the parenteral nutrition. Initiate feeding via gut as early as possible in 24 to 48 hours to maintain the gut barrier functions. Use nasojejunal feeding as needed for patient who cannot tolerate the gastric feeding, right? Whose gastroparesis is a concern. Nasojejunal tube is appropriate route to continue delivering the nutrients. And if patient has a low albumin, you supplement the albumin. It improves the prognosis of the patient in hypoalbuminemia patient with acute pancreatitis. And low albumin in acute pancreatitis is a prognostic factor. If it is low, it carries a poor prognosis to the patient. Is that clear to everyone? Yes or no?
Yes, sir.
Yes,
Yes,
sir.
sir. Yes, sir.
Wonderful. And last questions for today. Obese 57-year-old man presents to your office for pre-operative evaluation after he decided to have an elective inguinal hernia repair. The patient's medical history is significant for hypertension, diabetes, elevated cholesterol. Physical examination revealed he had a 3 out of 6 systolic ejection murmur. How many risk factor does this patient have? 4, 5, 6, 7, 8, or 9? Try to evaluate. This question is related with the pre-operative anesthetic risk assessment before surgery, pre-anesthetic risk assessment. So you think over the answer, you make a list how many risk factor this patient has, and this is absolutely important. So before any surgery, there are two clearance we are always taking, as you know, right? Anesthetics reference we do to to check anesthetist fitness, and another is a physician fitness. Am I right or wrong? Yes or no?
Yeah. Yes, sir.
Yes.
Yes, sir.
If the
Yes.
anesthetist say this is not fit, you cannot do surgery. Anesthetist give fitness, but physician say cardiovascular function is not good, you cannot do surgery. So both are important. So this questions related with the peri-operative morbidity and or mortality depends on the risk factor before the surgery. So we need to know what are the risk factor pre-surgery, and they wants to know now in this patient how many risk factors are there. Yes, post your answer.
Sir, 4.
4, yes.
Yes, who told four?
4.
Wonderful. Yes, Anisa, tell me how it is four. Count me
There's
one by one.
hypertension.
There is
Hypertension.
no 1 minute. 1 second, doctor. Sorry, I will write down. One is hypertension. Okay, one risk factor. What else?
Diabetes.
Okay, diabetes, second risk factor.
And elevated cholesterol.
Elevated cholesterol, third risk factor.
And the fourth
What
is
else?
age, maybe age.
Obesity.
Age. Age is a
Obesity.
fourth factor. Age is a
So
fourth factor.
obesity.
Obesity.
If you include obesity, then it is five.
Age is not the risk factor.
Sorry.
And
Hello.
Hello.
Yes,
Age
yes.
is
Tell me.
not the risk factor.
You tell me. You tell me. I posted this question. You tell me how many risk factors are there in this case?
I think obesity is not the risk factor, maybe.
Okay, fine. So your answer is four, right? Which is wrong answer. Fine. Anyone else?
Sir, 6 and
Okay.
systolic ejection murmur also with obesity.
Okay. So 3/6 is systolic ejection murmur is also risk factor. It is not a normal heart, no? 3 out of 6 systolic murmur. You need to evaluate for systolic murmur. Underlying aortic stenosis, underlying bad mitral stenosis. You cannot operate this patient. This is elective. This is not emergency. Elective inguinal surgery. Elective inguinal surgery. Whenever I post the question, I will never ever confuse you. Absolutely clear cut scenario I post in front of you. So it is not emergency inguinal, it is elective. You can tell the patient, okay, stabilize your blood pressure, reduce the weight, control the diabetes, control the blood pressure. We'll do it after 1 month. That's fine. It's elective, is not in emergency. No intestinal obstruction, no perforation. Is that clear, everyone? Yes or no?
Yes.
Yes, sir.
So concluding the talk, what is again last question? What, how many risk factors are there? Most of the people are saying four, right? Yes, Dr. Sabnam, what do you think? How many risk factors?
Sir, I also posted 4 because
Yeah.
age, male more than 45 years of age is one risk factor. Then
Okay, so let me
hypertension.
write down your, sorry. Let me
Okay.
write down your risk factor. Your risk factor age is one.
Yes,
Second,
sir. Sir, hypertension.
hypertension two. Third,
Sir, then this diabetes mellitus type 2.
diabetes three. Four,
Sir, elevated cholesterol.
elevated cholesterol. Four. So by you, obesity is not a risk factor. By you, systolic murmur is not a risk factor in this patient. If patient has a severe mitral stenosis and after doing the surgery, if he dies because of cardiac failure, is it good idea?
No, sir.
Are you getting me? Yes or no?
Yes, sir, I'm getting you, sir.
Wonderful. So this is the answer. The risk factor. Based on the patient's presentation, there are 6 notable risk factors for this surgery. Age is the risk factor. At 57, this age is factor in estimating the surgical risk, particularly particularly for age-related complication like post-operative delirium and many more. Obesity is a risk factor. Excess weight increases the difficulty of surgery, risk of complications such as infections, breathing problem, blood clot problems. 3. Hypertension, as we know, diabetes, we know, cholesterol, we know, systolic ejection murmur. This physical finding suggests potential heart valve disease or other cardiac issues which would require further evaluation or investigation by cardiologists in terms of ECG co and further things. Significant heart valve can increases the death or mortality and morbidity, means suffering, right, during the major non-cardiac surgeries. So concluding this talk with the 6 identification risk factor, the correct answer is C. If somebody does not agree, we can discuss. Is that clear, Dr. Sabnam? Dr. Nisha, is that clear?
Yes, sir.
Yes,
Clear,
sir.
clear.
Clear.
Yes, sir.
Wonderful. So thank you very much. I think I spoke with my full energy and based of my best knowledge for 90 minutes.
Thank
So
you, sir.
before I end up my session, I would like to have very quick feedback. What you learned most today? What you learned most? Or what is fascinating for you? Or is there any change in your mindset before class and after class? Now, okay, fine. I got some clarity. Now I will prepare in that way. Something like that. Everybody has different
Yes, sir.
experience, but I would
Yes, sir.
like to have little quick feedback. 5 minutes, if you can spare, I would be glad and happy and thankful to you.
Sir,
Sir,
every day is a new learning, sir.
we learned how to read the question nicely because in
One,
the last question I missed, sir, obese. That's why I left the obesity from the list.
wonderful, wonderful. So having a dog watch or dog eye on the MCQ is very important, isn't it? So each and
Yes,
every
sir.
word is
Yes, sir.
important. We sometimes we know the answer. I know everybody is brilliant, but we are in so much of hurry. Either we can't read the questions well, or we directly jump onto the answer. Believe me, again,
Yes.
I share my experience. This is my probably 1000 lecture I'm taking today, probably even more than that for last 12 years. In these questions, you probably have 90 to 100 seconds for each question. Spend, if you have 100 seconds for one question in whole paper, right? Maximum 100, right? Spend 95 seconds on question. Believe me, means 95% of your time spent on reading this. What exactly? And while you are spending 95 minutes, think of my triad. What is the diagnosis? What is investigation? What is treatment? Even believe me, I can guarantee you, without seeing the question, you can make answer. Believe me. When it is possible, when you have this part clear to you. If you have confusion in this, 99% your answer is wrong. 99% of answer is wrong. This is accumulate. Don't take it otherwise personally. This is my general experience. I also cracked DHA, then many Australian Medical Council and Kenyan board and medical board and all. Right. So I had also given many exams, but this is my general experience I'm sharing of many years. So try to read the questions as fine as possible. Spend 90% of time on reading the question. You make some impression in your mind what is diagnosis, investigation, treatment. I guarantee you see the same answer in the options. If you cultivate this practice, believe me, do it 1 day, 2 day, 3 day, and get back to me by next Sunday or next class how you have a change in this, your perceptions. So that's it. This is what my just experience I'm sharing. So anyone also wants to comment something on this class, lectures, something learn new?
So this is a wonderful tip given by you, sir. As like most of the times when we make a wrong choice, it is because we are in a hurry and we don't read the question properly. This is what I find that the main reason of getting a wrong answer. If we
Wonderful.
correctly see the question, that 90% of time the answer is in the question itself.
Exactly. There you are now. So answer is within the questions. Each and everything's are transparent, clear cut. But sometimes because of our knowledge, our hurry, our improper concentration, blah blah. So problem is not the preparation. We all are doctors. We all are brilliant, right? But sometime in hurry, probably we do some unwanted mistake, and we also confuse ourselves. BC. We know the answer, but still we get confused ourselves. This is what I believe.
Yes, sir.
Yes, anyone. Yes, Saleh, how was your experience?
Yes, doctor. I was just texting in the comment box saying that every question was a learning experience from a new perspective. The areas we don't usually look into, you have opened our eyes and enlightened us in a very distinguished manner. Thanks a lot for your explanation and enlightenment.
Wonderful. Thank you very much for your kind feedback. Yes, anyone else? Last but not the least, anyone wants to make any comment?
Yes, sir. This excellent lecture, and it was very informative and very easy to understand. And one thing I learned, give more time to reading question. That will help. That will help me.
Wonderful. Really will help you, doctor. 100%. 100%. Wonderful.
Thank you.
Yes,
अस्सलाम वालेकुम
anyone?
सर, ये सारे लेक्चर अपलोड होगा यूट्यूब पर?
Yes, sir. Upload होगा YouTube पर ये. Yes,
सर
sir.
पिछला भी रहता है यूट्यूब पर लेक्चर
I
अपलोड
will
होने
do it,
वाला?
sir. I will do it, sir, today. And I'd send you the link to you as well personally. Don't worry, sir. By
ओके
evening,
सर
I'll
जी,
do it.
ओके सर जी,
Yes.
ओके
Wonderful.
सर, अल्लाह
Anyone?
हाफिज।
Thank you very much. Anyone else last? Then we'll pack up the session. How did you learn something new today?
So
Yes, sir.
Yeah, go ahead.
Hello.
Make the
I,
subject very simplified and interesting. To make us to love the medical.
Your voice is, Dr. Sandhya, I think you are speaking, your voice is bit low. Can you speak bit little louder or keep your mic closer? Sorry.
So you
So
make
everybody,
the
yes,
very simplified and make us involved in that, and you really like want to love medicine and the
yeah,
way
I love
you
medicine.
teach us and yeah, the way you teach us and make it very simplified, very tough subject or tough topic, make it very simplified, and really we enjoy it.
Wonderful. Thank you very much for your kind feedback. Yes, yes.
So basically,
Or,
in lectures we learn how to approach a question. Like you don't need to mug
yes,
up like how to
that's
approach a
important,
question.
sir. Yes, sir. You are
That
right,
is
sir.
the main reason that lectures are very good.
Yes, sir.
And
All
you
right.
make this lecture very interesting.
sir, main thing is that we were in the whole MBBS also, and during our practice also, we are not focused on the triad that you make every time. So that's
Yeah, I do it every day for last 20 years, sir. Believe me. If I'm going
So this
tomorrow morning to my OPD in hematology, somebody coming with 5 HB, right, and breathlessness, I'll think, what is the diagnosis? How I supposed to investigate? What is the initial and base treatment? I do it in hundreds every day for last 20 years. And that makes me lots of clarity in my mind, right? So 5 HB does not mean blood transfusion. I need to see where is the blood loss. It's a problem in the bone marrow, problem in the GI tract, problem is where, why he has a 5 HB. You understand? That is real learning. Transfusion,
yes,
anybody can
yes,
say, even
yes,
nurse can say, oh, transfuse the blood, 5 HB.
mm,
That is anybody can tell. But why
yes,
5 HB? What's the problem? Whether it is correlating with the patient's sign symptoms or not? What are the positive findings in the patient? I can make diagnosis. You give me any, I'm not praising myself, but I did millions of times. Send me any CBC, only CBC without history. I can tell this CBC leukemia, this CBC lymphoma, this is ITP, this is chronic lymphoblastic leukemia, this is hemolytic anemia. Send me only CBC. This is iron deficiency. This is B12. Why? Because I did this practice thousands of times.
yes,
You
yes,
understand? So
yes,
that we need to do it in our practice. That we need to do and in practice, and it will not help you to crack the exam, but it will strengthen your clinical sense as well.
okay,
Clinical
yes,
sense, right? Where you are seeing in front of the patient, you can't open up the book, na. You need to
mm,
interpret something, right? Okay, chest
yes,
pain, he could have MI. Okay, go and do the ECG, enzyme, TROP-T, TROP-I, CKMB, you do it. Okay, it's elevated, you give MONA, blah, blah. This automatically comes to your mind while you are seeing the patient. That is what I'm doing. And that probably makes the difference.
yes, yes, sir,
So anyway, thank you very much
definitely.
all for your
Thank you.
kind this attention and listening me coolly and calmly. Once again, enjoy your Sunday. We'll catch you
Thank
with
you,
the
sir.
next class. Thank you very much and keep in touch with me.
Welcome, sir.
Thank you, sir. Thank you,
Thank you,
sir.
Thank
sir.
you very much. Thank you, Dr.
Thank you,
Rishi.
sir.
Take care. Thank you very much.